Okay, well, thank you. May I officially introduce our next two witnesses, Professor Gary Ford, who recently has joined the Academic Health Sciences Centre and Network in Oxford. And congratulations on that, Gary. And also Dr. Robert Winter, who I've known for many years. He was previously the medical director for the Strategic Health Authority and now taking the role of running the Cambridgeshire Academic Health Sciences Centre, or partnership, if I'm correct. So, welcome. You probably do know what we're trying to achieve here through this commission. This is the mayoral commission, and I'm very excited by it. And a lot of interest is sort of, if you like, developing a momentum in recent weeks, and very keen to hear your thoughts about what London's offer should be and how do we drive both. Obviously health is one aspect of this, but also the health and wealth agenda, which is the brief of this session. But if you want to get out of the brief of the session as well, you're welcome to do so. Don't feel confined to the health and wealth. So I'll leave it to you.
Okay, just to say, we haven't discussed or prepared this, so we may say completely different things. So we're two
Great,
solos,
that's even better. That's fantastic.
Duet. Yeah. And just a little bit by way of background of where I'm coming from in my perspective on this. I've never worked in London. I studied here a long time ago. And my perspective comes as a clinical academic and stroke physician who has led the National Institute of Health Research Stroke Research Network since its inception in 2005. So in that context, I've worked with the two local stroke research networks in London and had a national perspective. And as an R&D director in Newcastle for 7 years, where again I've had interactions with London sites. And then, as you've said, Lord Darzi, I've recently started in Oxford, but I've only been there 2 months, so I'm still learning what Oxford's like and trying to achieve much the same things London is. So, sort of my observations, and forgive me if they sound critical, they're not meant to be, but you've asked for a challenge.
Absolutely. Yeah.
So there's absolutely no question that health research in London's universities and hospitals is world leading. You'll all have seen the RAND analysis underpinning the Academic Health Science Centre process, where King's Imperial and UCL were in the top 5 in England. And you have 3 of the 6 HSCs, Academic Health Science Centres in England, working within 3 HSNs, which actually are, compared to some of the HSNs like mine, quite well established because they're underpinned by established academic health partner collaborations. But as an outsider, it certainly to me looks like the whole is no more than the sum of the parts in London. And it's not always supported by excellence in training and patient care in your NHS providers. So, for example, if you look at the training survey in the RAND analysis of the 25 organisations, the 3 leading centres were 18th, 23rd and 24th, which is sort of, it shows a mismatch between the strength of research. So I'm going to address 2 of the questions where I think I can provide comment. The first, how can the growth of London's health economy best be supported? I think the first is to maximise your academic and commercial research activity by ensuring your research infrastructure, your clinical research infrastructure is comprehensive, integrated and competitive. And I'm not sure if there's been a review of clinical research infrastructure in toto across London, but I'm sure a systematic review of that would be valuable in terms of thinking to the future, such as, does London have the infrastructure to be able to support all the stem cell research it wants to do, for example? And I'm aware of some of the infrastructure barriers with that, having dealt with bringing in a stem cell study from the US into UK centres. I think also, from my outside perspective, London does appear sometimes fragmented and uncompetitive. As an R&D director, where we would deal sometimes with contract negotiations with some of the London NHS partners, or as SRN director, the large NHS trusts were tended to be slower with approvals, slower with contract negotiations, and industry contacts who I talk to consistently report London sites are too expensive and uncompetitive. So I think a review of the commercial pricing strategy of your HEIs and NHS partners, if you can bring that off, might be helpful. But perhaps considering developing not undermining the autonomy of organisations, but some sort of London offer in terms of quality and setup times, but also price, where London is perceived to be an outlier, where not always justified by the reputational data quality. I think there's always a focus on medical academics, but I think it is worth looking, particularly because of some of the problems of recruitment in London, at the quality of training and research capability in your nursing, midwifery and NHS staff, and having a clear plan for that with your HI partners in that space, because that workforce is also critical to innovation in the medical arena. I think you have a unique opportunity to bring your industry partners into your healthcare training programs. We managed to do that in Newcastle, where we don't have the advantage of geography in our Wellcome Translational Medicine PhD training program, where a third of our lectures and seminars in the MSc were delivered by speakers from our commercial partners. And we found that was really valuable in developing links between industry and academia, which were not driven around specific project discussions, and that led to quite fruitful collaborations. I think Dr. Forster talked a bit about this, about developing more bridging across the three cultures of the NHS, universities and life science industry, and I think this is a challenge for all the HSNs. But I think looking at the opportunity to establish more joint appointments between academia and industry and between NHS and industry could improve understanding and collaboration. On the second question, how can the HSCs and HSNs contribute to London's health and economic goals? I'm struck by my experience of being an advisor on the panel that looked at the London stroke reconfiguration. Chris was involved with that, which was successful in bringing London from having some of the worst stroke care in England to the best. So there's a clear opportunity, I think, for the HSNs to work and commissioners to work collectively around service improvement. But I think there's also an opportunity to do what wasn't done with that process, which I regret we were unable to do, was to integrate review of the research infrastructure and governance changes around the service reconfiguration, because we did that afterwards in some respects, but it was not linked and it was less efficient for that. So we didn't address some of the research governance issues, and we could have had more investment in the hyperacute centres for research. And I think that these tend to be looked at separately, and clearly it is difficult to bring them together, but if London can do that, I think you would really reap dividends. As has been commented on by others previous to experts, I think all of the NHS needs to improve its uptake of new innovation, but perhaps London has an opportunity to be the leader and exemplar in England. So we're obviously looking at this as an HSN in Oxford, and I think there are two areas. One is to, through the HSNs and commissioners, get London-wide implementation of nice technology appraisals and service reconfiguration, and look how to do that. There's often the perception that the problems of uptake of innovation are cost, but I think there are many other barriers to it, including the one David was talking about around the because no one can fail in the NHS. If you don't adopt anything, you prevent failure, and I think that is a systematic cultural problem. And the second is to develop pilot early adoption schemes where you evaluate new commercial innovations at the point they come to market, where again you have a population of 10 million. If you did that London-wide, that would be very powerful as an offer to the commercial sector. And certainly that's the sort of plans we've got. In my own experience, I found it very helpful to support NHS Trust develop a commercial research plan. So you get the NHS focused on commercial research activity, looking at activity to income and the number of capable principal investigators in NHS services, and with a clear plan to, I think, of the HSNs to increase research activity in your non-research intensive NHS partners to increase research capacity. I think that point was made by an earlier speaker. Whether you should develop a commercial healthcare research plan for London, I think, is a moot point for the reasons been talked about, and whether that would be meaningful or feasible. So I think it's more about getting clear plans in individual organisations and then somehow collating those and being able to promote it at the front door. So I think of the, you asked for top three proposals. I would say think about undertaking a pan-London service review and reconfiguration of priority clinical areas, thinking about research and commercial research within that. And there are some obvious areas to do that, such as cancer and perhaps cardiac care. Develop London-wide innovation plans, both for implementation of NICE TAs and pilot models. And I think it's very important to invest in good data collection to know what you're doing, both in research activity and in adoption of innovation. And with that data, you hopefully over time will show you are leading compared to the rest of the country and make yourself attractive. But at the moment, a lot of opinions are not supported by good data. We certainly found that with the Stroke Research Network. People's beliefs were not underpinned by the activity when we obtained the data.
Thank you. Rob, do you want to add anything to that? Or?
I very much agree with much of what Gary has said, so I'm certainly not going to repeat. I'll just give a very, very brief synopsis of where I come from. I did actually train in London, Hammersmith and Brompton, UCH, and then moved up to Cambridge, where I was medical director, and then had the privilege of working with Lord Darzi on the NHS Future Review. And like Gary, I was National Clinical Director for the respiratory programme, and that gave me insight into many aspects of clinical care of respiratory disease in London. And then I moved back to Cambridge as Director of Cambridge University Health Partners, one of the 5 original academic health science centres. And from that perspective, I was able to work very closely, particularly with David, but also with the other 2 AHSCs. We've focused in Cambridge on building the Cambridge Biomedical Campus. We've had the opening of the new Laboratory of Molecular Biology 2, the biggest investment by CRUK in recent times, and just last year the announcement that AstraZeneca is going to locate its global headquarters and its large molecule research enterprise on the Cambridge Biomedical Campus. I've also been the clinical lead for the Small Business Research Initiative since 2009. And that's given me insight into the link between small and medium-sized enterprises and the NHS. And I have some comments in relation to that. More recently, I've been appointed the Managing Director of the Eastern Academic Health Science Network. So picking up a couple of points that Gary made. Firstly, I think that the AHSCs in London provide a unique opportunity for delivering on the tripartite mission of AHSCs, i.e. service improvement, research and education. And I see in the 3 AHSCs examples of some really innovative work. Now, I would look at the health economy as not just a wealth creation issue. I think it also maps to value in healthcare. And I think that the health economy element of this, in a sense, illustrates the need for reconfiguration, driven by observations around variation, observations about minimum viable size, observations about a consultant-delivered service. And I believe that the AHSCs and the 15 AHSNs are in an absolutely unique position to actually lead that, as they are in a position to lead the research and the education agenda. In terms of what is required, I think that, as the previous speaker alluded to, what industry, policymakers do not want to see is 15 separate organisations. And that's quite important, because the 15 AHSNs are at a very, very different stage of development. And I see London as collectively as an organisation that could actually lead this agenda. So in relation to industry, I think a collaboration between UKTI and the AHSNs would provide an extremely powerful platform internationally for UK biopharma and bioscience. In relation to the SBRI competition, which Peter Ellingworth knows extremely well, this is based on a similar scheme in the United States called the SBR, and its purpose is to fund small and medium-sized enterprises. And we in the EHSN ran on behalf of NHS England 8 competitions in October, spanning a range of clinical areas. We actually did this distributively so that each EHSN, including the 3 London ones, actually took the lead in one competition. We had 260 applicants, and we will be able to fund a fraction of those. But having been involved in the SBRI competition since 2009, I've been struck by the huge breadth and quality of innovation, and that can come from frontline clinicians or from companies typically employing from between 5 and 150 people. The challenge, I think, is for the AHSCs, AHSNs, and London in particular, to actually open doors to small and medium-sized enterprises. And I think there is much more that we can do in that respect. So, obviously, issues around research and big pharma have already been touched on by Gary, and I won't add to that. I think that the link between London and Oxford and Cambridge, the so-called Golden Triangle, is something that we could make a lot more of. We have the A1, the M11 corridors. You could describe it as the health fen. We have some of the most productive global giants like GSK and AZ. We have a wealth of science park, small and medium-sized enterprises. I think that collectively we should do more rather than as individual AHSCs, each actually forming individual relationships, which of course can go on, but I think collectively there is a real opportunity here. I'll pause there, I'm conscious of time.
Thank you. Thank you. Well, we have about 8 minutes or so. Peter, do you want to ask any questions?
Yes, please. Robert, thank you, and Gary also for that exposition. And I guess between you, you've touched on what could be the kernel of an idea here. Obviously bringing Oxford, Cambridge and London together. Gary, you said at the outset that really London wasn't the sum of anything more than the sum of its parts, and I think it's quite telling. And perhaps if we extended that to say the same for the 5 there. What do you think it would take, and particularly building off of the SBRI programme, because one of the things we've already heard this afternoon is that finance is going to make us or break us as a global offer. Right now it's not making us a global offer. So SBRI, great initiative, but doesn't really have the scale perhaps. And then is there a way that we could join these 5 and build on that finance beginning?
My observation about the SBRI programme, for those that aren't familiar with this basically gives £100,000 initially for essentially proof of concept plus. And then after 6 months, the successful applicants come back and they are given another £500,000. There is talk of a SBR3 to give more. What I have seen happening is some really good ideas being brought almost to market, and then the gap between moving from that sort of size to something that leads to a technology being manufactured in the UK, leading to further development. That is the gap, the valley of death, if you like, that actually the problem exists, and it links to the comments that were made about the availability of finance. It does strike me as somewhat perverse that we have possibly the 2nd biggest finance centre in the world, and yet we have some fantastic projects that are actually sold at that stage usually sold to abroad, usually the United States. I can think of several examples where we should be actually manufacturing the technology in the UK. And whereas pharma are quite good at this, good example is that there's a new inhaler from GSK that has come on the market last month. It's actually a major advance. It's a once daily inhaler. The research was done in Stevenage. The drug is produced in Montrose in Scotland, and all the inhalers are manufactured in where? Worldwide, where they've actually got 4,500 people working. I don't think that happens sufficiently in really good ideas that are actually dropped too soon.
Thank you.
Okay, thank you.
Any questions on this? Yes,
It was really interesting. Thank you to both of you so much. It was so clear. I wanted to follow up on the relationship London, Oxford, Cambridge. And it's not a rhetorical question. So there are 15 AHSNs nationally. There are 6 AHSCs. There are 21 organisations. And you tend always to have a sort of vertical reporting line in England. Always feels quite tight upwards. If we're to work together, I personally don't think I've been at a meeting that was solely of the 10 organisations we've been talking about, the 5 AHSCs, 5 AHSNs, Oxford, Cambridge and London. I personally don't think I've ever attended a meeting where the cake has been cut in that way. I've attended plenty of meetings where the universities have cut it that way, or the NHS has cut it that way. But actually, I'm just a question. I'm not sure I've been in that setting. And what could we do that allowed us to cut it in that way, cut the cake in that way sometimes, rather than always being cut in a different dimension? Or am I wrong and I just didn't turn up to the meeting?
No, I think you're right. I mean, obviously, since some of the HSCs like Oxford are very new, you could say there's not been the opportunity. In fact, not formally established until April, if I remember correctly. So there's nothing to stop us organising that.
There's nothing to stop us, but I'm curious why we haven't been driven to do it, because we've had many, many meetings of the 15 AHSNs nationally, more than I can probably count.
Agree.
We've had some meetings of the HSCs. So obviously the time is a factor. There's only so much you can do in life. But I wanted to perhaps also ask, how much appetite there was for that way to cut the cake. Because if you don't meet up, you don't work together.
Well, I mean, I would say the attractiveness of certainly England. Let's put Scotland and Wales out of this for the moment, Northern Ireland. To industry is critically dependent on those 6 AHSCs and the Golden Triangle in particular. So if London, Oxford and Cambridge were to, as it were, get those houses in order, particularly in terms of the collaborative working between the HEIs, the NHS partners and the associated local authorities. So, for example, in Oxford, my initial impression going there is quite a big problem with the infrastructure. Why isn't there a high-speed rail link from London to Oxford rather than up to Manchester? That would crack the UK's attractiveness, and in fact, that geographic area must be the strongest in the world in terms of its academic competitiveness in healthcare, the Golden Triangle. So I think all the HSCs have tended to be focusing very much on getting their relationships working. I mean, Robert may wish to focus on that, and as you pointed out, the HSNs are very new organisations in some parts of the country.
I mean, looking forward, I think that's absolutely essential. I think that we have to build an effective network of networks, both in terms of our afferent activity and our efferent activity. If we actually are a Balkan sort of republics with each individual AHSN, AHSC trying to make its own contact with pharma, smaller, medium-sized enterprises, informatics, diagnostics, internationally, we will fail. And I think the recognition of that should lead to us very rapidly, within the next 6 months, forming an effective network of networks. And the reason I think that it will happen is I think that there are now a number of really major opinion leaders who are linked to the AHSN. I mean, our own chair, Mike Rawlins, is but one. There are others. And they genuinely see the AHSNs as a potentially very powerful vehicle, but recognise that we have to actually be linked together in a way that to be frank, has not happened up until now, except in a very informal, rather random way.
But I want to push a bit further on this. I understand that drive of the 15 AHSNs linking together. I applaud it. I want it to work. But I don't want it to be at a detriment to this other cutting of the cake of the 5 AHSCs, 5 AHSNs, because otherwise the previous discussions we talked about, Oxford, Cambridge, London, won't happen, because you can only have so many discussions at one time. So it's how you manage to bring that together.
Well, I think you need to frame the question to get those to meet usefully, and it might well be that it could be framed around commercial activity and supporting SMEs, as Robert's outlined. I think that would be a highly interesting question to every HSC and also relevant to each of their HSNs.
Yeah. I don't think that's mutually exclusive. I think you can actually do both. And I think
to do both, don't you, Robert?
For AHSNs, peer challenge and peer support is going to be a really important driver to delivery.
So you think it's possible to do this without upsetting the other 10? That's really what's on the other one. I'm just exposing it, as we have to do both, don't we?
You can't do anything right, David, without upsetting anyone. So maybe the London Commission may get you together to talk about this. This might be the frame in which we could do this. So maybe Peter may engage you if that's...
absolutely. I'm more than happy to take that on, because I think the ambition there, as you expressed it, you think of the opportunity and the global beating scale of that cluster. That's what we should be focused on. And there are others there, but we won't go into that now. But let's start. Let's start with something that has got global ambition, that's got global quality. And we'll take the lead in stimulating a discussion, David, that brings us all together.
Yeah.
Absolutely.
I'll engage Elliot as well with this, I think.
Sorry?
Elliot Forrester, who was there before, he will do very
Absolutely.
interesting. I can't thank you enough for doing this, and also for being so frank. And that's really what we're looking for. So thank you for your time. Safe return back to the empires. Take care.